Well, I guess we can all weather the storm. We had a fairly good storm coming up in Boston just a few days ago, and everything was shut down. But so we came up here to New Hampshire to enjoy the outdoors, do a little bit of skiing, and have fun in the snow. And I figured while I'm here in New Hampshire, might as well take advantage of this time and do a little video for you guys on a case that I recently had. And I think this case is an educational case, and at the same time, it addresses a technique that I have developed, again, using is a technique I haven't described before, and it combines the idea of a non-surgical revision with a surgical apicoectomy immediately in the same visit by the use of the bioceramic putty as a means of improving the efficiency of doing this procedure. I think and I hope that after seeing how this can be done, this could be something that would be a benefit to you that you can apply clinically to help perhaps increase the predictability of your cases by applying a little bit of surgery in some specific cases, such as the one I'm going to talk to you about, in addition to your non-surgical revision or even surgical therapy, all at the same visit. All right, so this patient that came to see me was having acute pain associated with this maxillary right molar. And as you can see, the tooth has had a previous root canal, post, and a crown. There is somewhat of an open margin on the distal. It's usually not ideal, but this is a fairly recent crown. And you can see that there is a very large apical radiolucency around the mesiobuccal root, and that the mesiobuccal root canal fill is fairly short of the root end. Whenever I see a large radiolucency associated only with the mesiobuccal root of a maxillary molar, I'm fairly certain, without even having to take any type of a three-dimensional imaging, that we're talking about a case in which an additional root canal is present, such as an MB2 or sometimes an MB3, that is causing the problem and the persistence of the infection and its enlargement. So as we start always in these cases with a pan showing what the overall picture is, and you can see that this patient only had this root canal therapy in their mouth, and the CT is showing us also that we have this large radiolucency and bone loss around the mesiobuccal root that's expanding a little bit into the sinus with a little bit of sinus mucositis. This patient was in severe pain in this tooth. And we can see that there's a short fill, but there is room also on the side from this coronal section on the mesiobuccal root for an MB2 that was untreated. And now looking at the axial section, we can see where the MB2 was and is rather, and it was untreated. So in cases like this, what I try to do is, instead of having to plan for a full revision of all the roots, including removal of the post and doing the palatal root, which I can tell you ahead of time is something that is recommended by many endodontists, I prefer to do selective retreatment of the affected tooth or the affected root, with the idea and the explanation to the patient that this is a conservative approach, so it may require further revision down the line by addition of the other canals. But right now, by attempting to remove all of the posts and the canals, root canal fillings and the other canals, we expose this patient to additional risk of root fracture from removing these screw posts in this tooth, and as well as other problems, whereas the CT, as you saw, did not show any additional lesions associated with the distal buccal or the palatal root, and therefore it seems to me to be unnecessary at this time. We can always do that in the future. Now you may say, well, why not just address this tooth surgically? And here, because the CT shows that we've had a missed MB2, I always prefer to treat these cases non-surgically first, because what the apicoectomy would be tantamount to in these types of cases would be to just kind of put a lid in a garbage can by putting a little plug, as I explained to the patients, putting a cork at the end of the root to keep the bacteria inside the tooth. In these types of cases, I would prefer to clean the inside of the root completely. And normally you would want to wait and see what happens with these patients in terms of, do they need the surgery or not? My experience in the past has been that many of these missed canals, where the root canal in this particular case was done several years ago, there's a very strong established biofilm that is now present, and many of these cases, probably half-half, does end up requiring some additional curettage of these lesions that oftentimes end up being cystic in nature. And also when you have a patient that has acute pain, going in there and doing a revision on a patient with acute pain and adding all of the chemicals involved with the dissolution of the gutta percha and potential extrusion of some of the gutta percha and the biofilm during the retreatment process will certainly add a whole new layer of inflammation to these patients, and therefore cases like this should at the very least have a revision and probably a IND or incision and drainage at the same time. Now, some people prefer to do calcium hydroxide in these cases, but the technique that I'm going to show you now will hopefully show you how you can actually do the revision in the same, in a single visit if you're adding a surgical component to it at the same time by curating out the lesion and then proceeding to making sure that you have a retrofill. So now, the technique that I'm going to talk to you about is this concept that I talk about in non-surgical retrofill. And the idea as a whole here, to just summarize it before I show it to you, is the idea of filling the apical portion of the root with a bioceramic putty, such as the BC putty, fast set, which is my preferred putty material, and then to proceed and immediately go ahead and surgically cut the root off. And at this point, since you have your retrofill done with the putty at the apical portion, then you no longer need to do a retro preparation and the addition of a retrofill from the other end. I hope that makes sense. After you see it, you probably understand what I'm talking about. But the idea here is that you're actually doing your retrofill at the time of your retreatment by having the equivalent of an apical barrier technique, which I have described in much older videos in cases where you have an open apex, where you actually place a bioceramic putty to plug the apex and then fill the rest of it with hydraulic condensation. In this particular case, we're going to use the putty for an apical barrier, but then go ahead and proceed to cut the root off at about a couple of millimeters from the root end and end up with a putty fill at the end. All right, let's see it. I'm sorry I'm talking too much. Let's get to actually see the case so you understand. So in this particular case, as you saw, what I have done is I have accessed through the crown only over the mesiobuccal root. And what we do in these types of cases is after we've accessed and found the canals, the MB1, and then searching through this small little hole. And this obviously can only be done if you're utilizing a microscope because it's such a small space and you need to really be able to see the floor of the chamber. Use your triangulation from your MB1 in order to find your MB2. We find it. You always need to then isolate the tooth for secondary isolation using here in the sequence flowable dam material. And this is because I need to be able to see the CEJ for proper access and then add, after I found the canal, I then add this secondary isolation to seal the area, and then I proceed to do my proper irrigation, first removing the gutta percha with the chloroform, and then once the gutta percha has been removed and found, the MB2 has been found, now I'm going to move on to the use of TRITON, which also, as you know, is a sodium hypochlorite-based solution, and that is used here for our disinfection and the removal of this long existing biofilm with the addition of some ultrasonication and agitation. And then we dry the space. And at this point, we've found the MB1 and MB2, as you can see here, and we've done our full irrigation sequence and things are been cleaned out. And you can see that what the TRITON does during your irrigation process, it leaves this nice chalky and clean surface area inside your chamber as a result of your irrigation process. So we've done our irrigation, and now we're going to do, as you can see here from the x-ray, that I just take an x-ray to make sure we've removed all of the gutta percha debris, and all the gutta percha debris has been removed, and now we're going to fit in a size 4004 cone in the mesiobuccal on the MB1 and a size 3504 in the MB2. And then again, expose another radiograph, and we can see here the MB2 joins the MB1, and that's fine. And that part of the reason why these types of cases fail, despite the fact that the MB1 joins the MB2, is the reason why it took so long for this case to fail is because the tissue that was left in the MB2 and was untreated takes a while for it to be necrotic and work its way around the MB1 to cause the infection. That's part of the reason why, whether MB2 joins MB1 or not, it should always still be cleaned out adequately and completely before we proceed. Okay, so now I want to talk to you about the technique for doing what I just talked about, which is a non-surgical retrofill. And the idea is once I have fitted these cones to the apex, now I'm going to remove about 4 millimeters from the apical portion of these cones. And as you can see here, I'm using the scalpel to cut off the last 4 millimeter of this fitted cone to the apex. And then, as you can see, when I'm putting it back inside the canal and expose another radiograph, you can see that we have 2 plungers or 2 custom fit pluggers that are about 4 millimeters short of the apex. And at this point, what we can do is we can place a little bit of the putty material into the canal and then push it down with these custom fit pluggers that we have made, or place the putty at the apical portion of the cone and push it down. Of course, before we do that, we always need to place sealer in the canal, because in essence, this is the same as the lid technique of combining the flowable BC sealer high flow as the material that is going to fill in the little nooks and crannies. And then we're using the putty, and you can see the way I'm doing it. I'm just putting it here at the tip of the gutta percha cone here, and almost making a cone that is apically of the putty material, and then taking it and plunging it down and pushing it down to the length that I have predetermined for this to go. I'm also then using hydraulic condensation in it, and the tip that you just saw is actually a new tip that I've designed. It's not yet on the market. We're in the process of making it, and this tip, as you can see, makes the idea of hydraulic condensation much easier and a much more efficient process. So once the coronal portion of the MB1 has been cut off, we do the same exact thing with the MB2, and then insert that also into the MB2 canal, making sure that it goes all the way down to the apex. And now that is seated too, and do the same process of hydraulic condensation with the MB2, and then plug that down. And now what we've done, we've actually obturated the root canals with the concept that the apical 3 millimeter of these canals have been filled with the putty fast set combination. Now, at this point, we place BC liner, and I use the blue BC liner, as I've mentioned before, in the axis preparation. And now very quickly in the same visit, we proceed to do a quick incision right in the, and I'm doing a submarginal triangular incision here. And we go in there and quickly reflect a flap in order to be able to enucleate and remove and curettage the large lesion that was at the apex. But of course, before that, I forgot to say that we're going to take a quick radiograph after our fill to make sure that the fill looks okay. And you can see that we have the fill of the MB1 and the MB2. There's a little tiny puffs of sealer out as well, which is not a problem. But in this point, doing the incision and then reflecting the flap is important in the sense that we're going to now remove the inflamed tissue for this patient so that we can guarantee the patient is not going to have any additional discomfort in this area. This could have been just in the form of an incision and drainage, but we might as well, since we're going to get down there surgically, to actually completely enucleate and remove the lesion and perhaps send it out for biopsy so that we can find out if everything is okay. And we can see the lesion in this area, and we just proceed to remove it, curette it out, and then all we need to do at this point is to use our liniment bar. And I'm in the process of actually redesigning the liniment bar. These types of resections make them a little bit easier and more predictable using CBCT. And then we proceed to just kind of clean it out. And that's all we had to do. We just shaved off 1 millimeter or 2 from the root end. And then we kind of take a look at it because of the fact that the MB1 and MB2 oftentimes have an isthmus. In these types of cases, now we don't necessarily have to place you can see that everything looks nice and clean here at the apex. But since the water from the handpiece can sometimes create a little bit of a divot in the canals because the putty is not yet fully set, since we're doing the procedure right away, all I do is just take a little bit of the putty and just smear it at the apical area of the tooth and then brush over it, and that can shove the putty into any of these divots, and potentially even if there's any isthmus that is open, that could fill that as well. Now, this is not quite as kind of involved as doing a retro preparation in each canal and then also preparing the isthmus in between the two. But as you can see, this is a super quick technique. Literally in 5 minutes, you can reflect the flap in this way and curette out the lesion. And in this particular case, we sent it out for biopsy, and it turned out to be an acute abscess and granuloma. So essentially what we used to previously call a phoenix abscess, which is an acute exacerbation of a chronic abscess preparation. And then we proceed to go ahead, put some resorbable and absorbable sutures. I always like to use the gut suture for these types of cases because I want the sutures to kind of dissolve within a week for better healing very quickly. And so this is it. The case is finally done. And as you can see here, after I'm done, I always use a timer to measure the time of my entire procedure. And we can see that from the beginning of the procedure to the end of the procedure, this is from the time of actually when the patient comes into the chair, I count the time all the way to when they leave. We've done the revision through the crown, and we did the surgery in the apico and the sutures. We called in the patient the following day, and the patient actually had absolutely no pain at all. And that's what's wonderful about surgery. You'd be shocked to know that if you do your surgery cases quickly and efficiently and don't end up using a lot of hemostatic agents that are very inflammatory, that post-surgical patients have less pain than post-non-surgical patients in terms of the healing of the area. In fact, the 1 hour and 18 minutes it took for this patient from the moment that he walked into the operatory until the patient left, a lot of time was taken from just changing the operatory setup from a non-surgical case to a surgical case by the assistant. This could easily be done in about an hour if we set this up with a kind of a plan to do these things. And I knew I was going to do this ahead of time. I had told the patient, so he was obviously ready for it because once we started, he had a lot of acute pain. And I didn't want to have to do this procedure to put calcium hydroxide. The patient would have had pain for a few days, acute pain from the procedure, and then have to come back again and do it, and then have the patient come back for a follow-up to make sure that they need surgery or not. Doing the whole thing in just about an hour and 20-minute visit is incredibly efficient. Now, we don't charge in these types of cases for two separate procedures because obviously that would be unethical, and this is a way we're just going to charge for the non-surgical revision here, or you could charge just for the surgery, but then throw in the non-surgical in there. If you just think in terms of what's best for the patient's prognosis and be more definitive in your approach, you're going to be completely fine. And the patient's obviously happy because we addressed the problem in a far more definitive way than in a tentative approach of, well, let's just do the non-surgical revision, let's watch and see what happens and so on. And now the patient's doing well. Now, this was done very recently, so unfortunately I don't have a recall to show you, but I'm willing to bet that it's going to work out just fine. And for that reason, I will certainly follow up and share with you the results of the case as soon as I have him back for a 6 months follow-up. Anyway, I hope this was educational and helpful to you. I think this is a very nice technique to be able to apply to your cases clinically, in which you are going to have to do a revision on a tooth that's acutely inflamed and it's surgically accessible, and you're able to address this issue. And you might as well just very quickly do the surgery right afterwards by applying this technique, because most of the time in your surgical cases, most of the time and difficulty of surgery is not in the access or in the flap raising. It is actually in the process of retrofilling. And this technique, in my opinion, will help reduce the time of surgery, and it will help you in cases in which you have probably very difficult access. You're close to the infraalveolar nerve, you're close to the mental foramen. This is going to allow you to do this non-surgical retrofilling, and then all you have to do is just to go in there, clean the lesion, and do a resection, which really is the least technically difficult part of doing the surgery. The most technically difficult part of the surgery is actually the placement of the retrofilling, especially in difficult to access and reach areas where you are close to vital structures. All right, this technique has not been published yet, but these videos that I do for you guys where I share these techniques, they're considered publications as they're all time-stamped, as you can see on YouTube. So you can consider this video as the source material for any of you guys who are interested in doing any potential research in this technique of combining these two, using this non-surgical technique, and find out how does it compare in terms of success rate to the other, just a direct surgical technique. Now, of course, this is not feasible in many of the surgical cases that you need to do if you don't actually have access to the apex of the tooth. But if you have access to wherever the problem is. If you have a perforation, if you have a ledge, if you have a instrument that is separated, you can clean up to that area and then place the putty in the technique that I just described, the non-surgical retrofill technique, and then surgically just resect up to that point, and now you have your retrofill, and that would be very quick surgically. I hope this was helpful to you. If it was, let me know in the comments what you think about this technique. Do you think this non-surgical retrofill technique is helpful? Can it work? And we're going to have to wait for some of the research to come in and show how it compares to a conventional retrofill technique. Again, it's very niche. It's not a universal technique to completely replace conventional retrofilling technique, but in cases where it's indicated, it could be very helpful to both you and your patient in terms of the efficiency and as well as the predictability of the outcome for them. Of course, in a case like this, if the conventional way doesn't work, if the isthmus had an issue, you can always just go back surgically and then just fill the isthmus if needed. But I'm fairly confident this would work out just fine, and I'll follow it up with you and share it with you. Sorry for the long video. I hope it was worth it. Until the next video, let's save some teeth.